Hi, this is Brian Kim. I'm going to share with you case number 53 in the Best Way to Do Cataract Surgery series. This is a patient who has very irregular surface, and so because of that, it's really making it more of a challenge. You can see there's significant corneal surface irregularity, but I'll use double chop, cross chop, mechanical fracturing techniques to disassemble the lens confidently despite the poor view. So you can see this is a very irregular surface, especially on the right side and centrally. I'm using a cotton tip to help me straighten the eye, and I'm using a corneal marker to help me center and size my rhexis. I use a cotton tip to turn the eye, and then I'm making my paracentesis incision, first on the right side and then the left side. I'm making sure I have a nice corneal shelf, which is flat to the iris plane, and having that corneal shelf will allow me to have a nice self-sealing corneal incision. This happens to be the right eye. I'm injecting some intracameral lidocaine and some dispersive viscoelastic to fill the anterior chamber. And this is going to be the triplanar corneal incision. I'm going to make a vertical groove, place the blade into the deep part of the groove, using the cannula to turn the eye away from me as I make the groove and tunnel through the cornea. I'm using the cannula to turn the eye towards me, and then I enter. That's the triplanar corneal incision. I'm going to do my puncture style capsular rhexis with the teeth sideways. I go in and then puncture centrally. In patients where the zonules are loose or weak, it's hard to puncture with the forceps. I'm going to switch it to the cystitome. So again, I couldn't really puncture using the forceps because this is a pretty elastic anterior capsule. And so I'm going to use the cystitome to puncture. So I puncture and then sweep it to the left side and create a nice little flap. I grab the edge of the flap and going around circumferentially, trying to use the marks of my corneal marker to help me to center and size the rhexis. So again, I'm going around circumferentially, grabbing and re-grabbing, making sure I get a nice sized and centered rhexis. So go ahead and burp the viscoelastic from the wound. And this is a capsular fornix hydrodissection technique. Place the cannula out to the contralateral equator, point the tip down, get a nice fluid wave, decompress on the left side, go to the right side, turning the tip down, and the lens spins nicely here. You can see the epinucleus is attached to the endonucleus when the lens starts to spin in that manner. Irrigating the surface of the cornea. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. And then I'll remove the surface epinuclear material. Place the chopper underneath the rhexis edge to the contralateral equator. Turn the phaco tip vertically sub-incisionally, bringing both instruments together, crushing and dividing the lens. This is the double chop. Place the chopper out to the equator underneath the right heminucleus, pulling it centrally towards the phaco tip, and that's the cross chop maneuver, using high vacuum as well as the chopper to pull the piece up out of the bag, the first quadrant up, and then the second quadrant. Turning the second heminucleus in front of me, placing chopper out to the equator, pulling it centrally, dividing the second heminucleus in half, using high vacuum as well as mechanical fracturing forces to remove the lens pieces. Place the chopper around the fourth quadrant, crushing it and dividing it, and then using high vacuum to emulsify the lens pieces. This is the last piece. I placed the chopper around the lens piece, pulling it up, crushing it with the chopper and the phaco tip, and then using high vacuum and some burst of ultrasonic energy to remove the lens pieces. Now I'm starting to remove the epinuclear material. You can see this was somewhat of a soft lens, but it was a sticky lens. There's a piece that stuck to the cornea. Again, that just confirms that the cornea was nicely coated with viscoelastic. I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. I start to polish underneath the rexus edge. Most of the cortex came out with the phaco, but there's these fine wisps that are still attached. I switch to the polish mode and I'm teasing underneath the rexus edge, removing the lens epithelial cells. There's so many wispy lens material here, so I'm just taking my time, making sure I attack all the little fine wisps all around the anterior capsule as well as posterior capsule. You can see the capsule's kind of puckering a little bit. That just tells you there's a little bit of a stretchy zonule element, stretchy or weak zonule element to this patient's bag. There's some stubborn cortical material that's attached to the bag subincisionally. I'm using the polymer tip to tease that off. So once I'm satisfied that the bag is clean, I push BSS into the subincisional capsular fornix space. And of course, I figured there was going to be some lens material stuck, so it's being liberated using that flush. Inflating the bag is so important in this technique. I used to not keep the bag inflated, and I did break the bag in one instance. And so ever since I keep the bag inflated and I flush, I have not had that problem. So I inject some cohesive viscoelastic to fill the bag, and then I start to sweep underneath the rexus edge. Whenever you have a lens like this where the epinucleus comes off with the endonucleus during phaco, most of the time that means that the cortexes had not been teased off in a controlled manner from the anterior posterior that we do with the INA, and so there's just a lot of fine wisps. So in my opinion, really having cortical cleaving hydrodissection is really not the best technique because you have to go back and remove all these tiny wisps, which is really a problem. So I inject a single piece of acrylic intraocular lens into the capsular bag, and then I go in with the INA, inflating the bag completely, disengaging the haptics off the optic, tilting and going underneath the optic, rotating at 90 degrees and removing all the viscoelastic from within the bag. I reposit the optic back into the bag, and I'm polishing underneath the rexus edge now. And then I turn the haptics horizontally. So I switch to the visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So you can see this patient has really a terrible cornea. I don't know if the patient has just severe dry eye or epithelial basement membrane disease, maybe both, but it really did affect my view. And again, some people have success using methylcellulose. I did not have methylcellulose. I don't think this coat is really a great corneal coater in this situation, but I could be wrong. Other people might have success with it. But I went ahead and used double chop, cross chop mechanical fracturing techniques to very carefully and systematically disassemble the lens despite this annoying surface haze from the epithelial irregularity. And so I'm able to very confidently disassemble the lens because I know what I'm doing, where the instruments are, and this patient did quite well. So I hope this was helpful to you, and I thank you for your attention.